Half of the US healthcare system is priced using data the government no longer fully trusts. That's not a headline, it's a constraint. And once a system hits a budget limit, it doesn't debate. It rewrites itself. This story isn't about who's right or wrong. Not insurers, not doctors, not the government. It's about what happens when federal spending runs into a wall. For years, Medicare Advantage grew quietly and successfully. Instead of paying for each service, the government paid insurers a fixed amount per patient, adjusted for how sick that patient was expected to be. The logic was simple. Sicker patients cost more. Healthier patients cost less. Diagnosis became the signal, not as a moral judgment, not as a trick, just as the language the system used to price care. And that system scaled fast. Today, roughly half of Medicare beneficiaries are in Medicare Advantage. What used to be a side program became a core pillar of federal healthcare spending. That's when the math started to matter. Over time, something subtle happened. Patients in Medicare Advantage didn't necessarily become much sicker than those in traditional Medicare. But on paper, they looked sicker. More diagnoses, more documented conditions, more complexity. From a system perspective, no one had to be doing anything wrong for this to happen. When payment depends on diagnosis, organizations respond rationally. They document more carefully. They classify more completely. The signal didn't break overnight. It drifted. For a long time, that drift didn't matter, because deficits were manageable. Interest costs were low, and Medicare Advantage was still relatively small. That world is gone. Today, the federal budget is under pressure from every direction. An aging population, rising interest expense, mandatory programs consuming a larger share of spending. In that environment, automatic payment growth becomes dangerous, especially when it's driven by data the government can't fully verify. This is the key shift. CMS didn't wake up one morning and decide Medicare Advantage was flawed. The budget did. Once Medicare Advantage crossed critical scale, diagnosis inflation stopped being a technical issue and became a fiscal one. Every additional diagnosis wasn't just a data point, it was a future spending commitment. Automatically, and at scale. At that point, the government had no good options. It can't abandon diagnosis-based payment. It can't return entirely to fee-for-service, and it can't let spending grow on autopilot. So it chose the least disruptive path. It tightened which diagnoses count. It demanded stronger documentation. It reduced how much certain conditions increase payments. And it increased audits. Not to punish, not to moralize, but to regain control. That's when sponsor behavior begins to change. Again, not because anyone is right or wrong, but because incentives changed. Aggressive Medicare Advantage expansion becomes less automatic. When diagnosis becomes harder to monetize, growth requires more discipline. Sponsors become more selective about where they expand, who they enroll, and how quickly they grow. Expansion doesn't stop, it just slows. At the same time, strategies rebalance. Some sponsors lean more heavily back into traditional fee-for-service participation, not as a retreat, but as diversification. When risk-adjusted payments become less predictable, fixed payments feel less stable. Fee-for-service brings lower margins, but clearer rules. That trade-off starts to matter again. Benefits begin to change quietly, not through headline cuts. The consumer won't see a higher bill for this, at least not at first. They'll see a smaller network, longer approvals, and more quiet no's from their insurance carrier. The cost shows up in experience before it shows up on a statement. Operational focus shifts as well. Less emphasis on finding diagnoses, more emphasis on controlling utilization. Care management replaces chart review. Cost containment replaces coding intensity. The business model adapts. Services aren't eliminated overnight. They're repriced. Sponsors take a harder look at which services actually reduce downstream costs and which only made sense under looser diagnosis rules. Some offerings shrink. Some disappear. Others remain because they genuinely work. No judgment, just adjustment. From the outside, none of this looks dramatic. There's no single rule change that explains it. No press release announcing a turning point. But from inside the system, the direction is clear. Diagnosis used to mean how sick you are. Now it often means how well your system documents. In macro terms, the metric became the target. And once the target is captured, the metric stops telling the truth. That's not a healthcare opinion, it's a system reality. And this doesn't stop with Medicare. Any system that prices spending based on self-reported complexity eventually faces the same question. What happens when the signal drifts and the budget can't absorb it anymore? You don't have to decide who was right. The system already did. Once budgets force the decision, there's no appeal, only adjustment. This is Global Notes by JP. If you found this helpful, comment, like, share, and hit the bell. We're building the strongest macro community on the platform, one signal at a time, together.